I'm Dr. Jyotika Kumar, and today we'll be taking up the second session of your image-based questions. All right, image-based questions have been catching up in all kind of entrance examinations, so we cannot be far behind. We need to catch up as well. All right, so let's take up the second session and start with the questions here. Now, let's look at the first question. Look at the picture. Okay, so this is a picture over here with the patient lying in a lateral position. Okay, what are the hints here? And the patient is lying in a lateral position. We have markings present here. One is the marking of the PSIS. Okay, the PSIS is shown here. The other marking is of the sacral hiatus. Okay, PSIS and the sacral hiatus. And what it is forming? It is forming a triangle here. And this sacral hiatus has been formed. Okay, now just by looking at it, we know that we've read something of this sort in our chapter on regional anesthesia. Okay, and what is this space? What is this marking? This is the marking for caudal anesthesia. Okay, the caudal space. All right. So this is the marking for caudal anesthesia. Now let's go ahead and look at the question. Where is the local anesthetic given in the process in the image shown? Okay, so the process we clearly know is the process of caudal epidural anesthesia. Okay, so where will be the drug deposited? It is going to be deposited in the epidural space. Okay, so let's look at our options. Subarachnoid space, no. Subarachnoid space is accessed with the subarachnoid block or the spinal anesthesia. Epidural space, yes, it is the correct answer. Both, none, no. So we know that the epidural space is the correct answer. Okay, let's look at a few other points about caudal anesthesia. Now, caudal anesthesia, you should know, is used majorly in pediatric patients for regional anesthesia. Okay, for regional analgesia. All right, and how do you achieve it? You achieve it by giving local anesthetic into the caudal space. And how do you access the caudal space? That we've just seen with the this particular technique of making a triangle with the PSIS and the sacral hiatus. What amount of drug do you give? Now, the amount of drug that we give is established with the Green-Armitage formula. Now, what is this formula? Now, this formula tells you about the volume of the drug that you need to give in a patient. Now, it is given in the concentration of 0.25% and the volume of the drug that we give, that it is 1.2 ml per kg or 0.8 ml per kg or 0.5 ml per kg. Okay, now this is given for thoracic surgeries or upper abdominal surgeries. This is given for abdominal or lower abdominal surgeries, and this one is used for pelvic procedures. Okay, simple. So this is your Green-Armitage formula. Now, caudal anesthesia or caudal analgesia is used for patients up to which age? It is generally used for patients up to 8 years of age. Why? Because the sacrococcygeal membrane gets ossified beyond this point. It gets ossified beyond this particular age, and hence it becomes difficult to access your caudal space after this age. All right. So this is about caudal anesthesia. Next, let's move on to the next question. Now, the next question here is a picture of two electrodes being put on the ulnar side of the hand. This is your ulnar side and this is your radial side. Okay, and it is connected by two cables to a monitor here. So this looks like an NMT. It looks like a neuromuscular monitor. What is a neuromuscular monitor used for? It is used for assessing the neuromuscular blocker onset, its intensity, and to assess the reversal. Okay, so this is what the neuromuscular monitor aids in. All right, the most common stimulus that we use with the neuromuscular monitor in clinical practice is TOF. All right, and what are the nerves that are most commonly used? The most commonly used nerve is your ulnar nerve. And that is the question here. During neuromuscular monitoring, most common nerve used is, which is also shown in the picture here, is the ulnar nerve. Okay. And what do you assess with it? You assess for the response in the adductor pollicis muscle. You assess for the response of the adductor pollicis muscle in your hand. Okay, so you will be assessing this contraction here. All right. Now, the most common stimulus that we use is the TOF. Another very commonly asked question in your image-based question in neuromuscular blockers is about TOF and the fade response. Now, whenever you give a stimulus of train of 4, you've got 2 responses. Okay, you either get fade or you do not get a fade response. Now, fade response is seen in non-depolarizing muscle relaxant, and no fade response or fade is not seen in depolarizing muscle relaxants. Okay, so this is one question which you need to remember here. Okay, now let's move on to the next question. Now, this is a picture here and it says the instrument shown is used for. Now, until and unless you know what this instrument actually is, you'll never be able to answer this question. Okay, and this is a repeat question. Okay, this has been asked previously. So this instrument that is, or this device that is shown over here, it consists of a bag, as you can see, and this is a mask with the connectors and the valves here. This is an AMBU bag. Okay, this is what it's an AMBU bag, which is used during resuscitation. It is used for resuscitation. It is used during CPR. Okay. Now, what happens with this AMBU bag is when you compress the AMBU bag here, it delivers or it ventilates the patient from here. Now, AMBU bag can give from 21% to almost 100% oxygen. All right. Now, how do you use this mask? This is a transparent mask. Okay. You form a C and E with your hand. You do a C and E technique. You form a C with your thumb and your index finger, and an E is formed with the rest of your fingers. All right, when you use this mask, it forms a seal here. Okay, and the E is formed here. One on the chin, the other is there on your mandible, and the little finger is present on your angle. Okay, it is present on your body, and then the angle. And the angle one is used to lift the chin in front. Okay, so this is the C&E technique that you use during resuscitation of a patient. All right, and this particular ambu bag is used for ventilation of the patient. It is not used for chest compression. It is used for ventilation. All right, now let's move on to the next question. This is a capnograph. All right, capnographs, they form a very important part of your image-based questions in anesthesia. All right, it's extremely important. Now, the graph over here, it shows a shark fin pattern, and that's what the question says. Shark fin capnograph is seen in which condition? Now, this is something that you have to know. Normal capnograph, if you see, what does a normal capnograph look like? It looks something like this. Okay? Okay? Looks something like this. This is your EtCO2 value that it pertains to. This is phase 1, this is phase 2, this is phase 3, and this is phase 4. This is your dead space gas. Here are your alveolar gases which come out with the dead space gases, of course, which come out. Okay, here only your alveolar gases are coming out. And this is the phase of inspiration. So this is the phase where the CO2 gets diluted with your inspired gases, your oxygen and nitrous oxide. All right, so this is your expiratory phase and this is your inspiratory phase. All right, now this is the normal graph. The normal EtCO2 value is 35 to 45 mmHg, and the normal PaCO2 value is 40 to 45 mmHg. The normal gradient is of about 4 to 5 mmHg gradient. That is the gradient between these two. Okay, that's normal. Now, EtCO2 values can increase or decrease. What does the EtCO2 assess? It assesses for three things. It assesses for your perfusion. It assesses for the metabolism, the generation of carbon dioxide at the cellular level, the exchange of gases which occurs because of a proper perfusion or proper circulation that happens, which causes transportation of gases from the cells up to the lungs. So that's perfusion for us. And then, of course, the ventilation. Whether there is occurring an exchange of gases in the air, or whether CO2 is going out and coming in or not. All right. And oxygen is coming in, basically. Oxygen is coming in and CO2 is going out. So this is what it assesses. Now your EtCO2 value has a sharp increase sometimes. It increases like this, which is the shark fin pattern. When does this happen? Now this happens and the alpha angle increases here. Okay, this happens whenever there is an obstruction to expiration. Expiration is not occurring properly, and because of which the carbon dioxide will be retained inside and there will be a sharp shoot rise of CO2 levels inside your body. Okay, so CO2 will increase, EtCO2 will hence increase. So this is seen in obstructive condition of your airway, and a disease where you see this kind of obstruction is bronchial asthma, where there occurs constriction of the bronchial musculature. Okay, so this is what we have to know here, bronchial asthma. All right, now let's come over to the next question. Here what we see, this is a CVP set. This is what? A central venous catheter, and it's set with the syringe with its finder needle, with a dilator, with the catheter, the blade, and the attachment for fixing it to the skin. Now, the technique that we use for insertion of the central venous catheter is Seldinger's technique. Okay, this is what you have to remember. All right, what are the sites of insertion of the central venous catheter? It's another question that we can be asked. IJV, which is the most common one that is used, and it gives you a very accurate value. Why? Because the IJV is valveless. Okay, another site that we use is the subclavian. Now, the subclavian is the site which is contraindicated in which patients? In bleeding diathesis, because it is very difficult for you to compress the subclavian artery in case an accidental puncture occurs into the subclavian artery. All right, so that's important for us over here. Subclavian vein has got minimum chances of infection. The chances of infection are more with IJV as compared to the subclavian vein. The chances of infection are maximum with which vein? The femoral vein. This has got the maximum chances of infection. Which central venous catheterization will have higher chances of embolism or thrombi formation? Again, it's going to be the femoral vein. So you will avoid putting the femoral in non-ambulatory patients or patients who are prone for DVT. Okay, so this is what you have to know about the sites of central venous catheterization. Okay, now what are the indications? The indications of central venous catheterization, they include when you want to assess the fluid status of a patient, when the patient is on inotropes. Okay, and you put it in patients who need dialysis. Okay, so these are few of your indications that you should remember for central venous catheterization. Now, the next question we come to is this picture where we can see a patient whose teeth have been clenched and there appears some sort of spasm here, some sort of intense muscle contraction of your facial muscles. Okay, so this is what is seen. Here is the masseter spasm. Okay, so let's go ahead with the question. Masseter spasm is seen with scoline, thiopentone, midazolam or cocaine. Okay, so the answer here is scoline. Okay, so the answer over here is scoline. All right, now let's know a few details about it. Now, masseter spasm is a characteristic feature of malignant hyperthermia, and scoline is one of the drugs that causes malignant hyperthermia. All right, and masseter spasm occurs itself with scoline in low doses, when it's given in low doses. There are other drugs which are responsible for malignant hyperthermia and further, of course, with the masseter spasm. They include inhalational anesthetics like desflurane, isoflurane, all these drugs, sevoflurane. They lead halothane. Halothane is again a very important drug which leads to malignant hypothermia. Okay, so what is the treatment? You do a symptomatic management, of course, over here, and the drug of choice is dantrolene sodium. Okay, the drug of choice is dantrolene sodium. What is the characteristic finding other than masseter spasm? Is a sudden rise in EtCO2 which does not respond to treatment. It will not respond to your changes in the ventilation. Okay, there will be so much CO2 produced, and your soda bicarb will get used up. Okay, so this is what we have to know about malignant hypothermia and masseter spasm over here. Okay, now let's come to this question. This again is a graph here depicting the expired EtCO2 values with the time curve over here. Now you can see notches here. Okay, the graph depicts bronchospasm, spontaneous respiration, cardiac oscillations, none. This represents curare notch. Okay, which signifies the coming back of a patient from muscle relaxation. So that signifies spontaneous respiration. That means it is time to top up the patient with a muscle relaxant so that we can paralyze the patient again and stop the patient's spontaneous efforts of breathing. All right. Bronchospasm, we've seen how it appears. It looks like a shark fin pattern. Okay. Now, what do cardiac oscillations look like on a capnograph? They will look something like this. This is a normal graph as such. There's no abnormality. It is seen in lean and thin patients where the cardiac oscillations appear easily. Okay. With the heart beating. So these are the cardiac oscillations. Okay. The other graphs that you should know, when your EtCO2 value decreases, this is the normal EtCO2 value. This is a graph of hypoventilation. When your EtCO2 value increases abruptly, that is, sorry. One, two, three. This is the graph of hyperventilation or CO2 washout, or CO2 is getting washed out, and hence your EtCO2 value will be less than 35 mmHg. Now, if your EtCO2 value is way above normal, that is, it is more than 45, that's a sign of hypoventilation. Okay, the ventilation is not happening properly and your EtCO2 value is rising. Now that can be one cause. What can be the other cause? Maybe we are having a hypermetabolic state. Okay, if you're having a hypermetabolic state, that can have high EtCO2 values like hyperthyroidism or thyroid storm. So this can be again an MCQ based question for you. Thyroid storm. Another condition where you can have a hypermetabolic state is shivering. Okay, so that is another condition. Now, malignant hypothermia can also give you this condition. Okay. Whereas over here, on the other hand, hypometabolic state will have low EtCO2 values. For example, hypothyroidism and hypothermia. Okay, so these are the conditions that we need to be aware about, and these are the conditions where you can be asked your image-based questions on capnography. All right. Now, this is the next question, atracurium. Okay, we can see that this is an image of a drug which is atracurium. What is atracurium? Atracurium is a muscle relaxant. Okay. Atracurium is the drug of choice in renal disease, liver disease, both none. For this, you need to have adequate knowledge about atracurium. Okay, so atracurium is a muscle relaxant which is metabolized by Hoffman's degradation. Okay, it is metabolized by Hoffman's degradation, one majorly. The second, 25% of it is also metabolized by ester hydrolysis. Okay, so these are the two ways in which it is metabolized, but it does not undergo metabolism in the renal, in the kidney and in the liver. So it will be safe to give them in liver and renal diseases. So your answer is going to be both over here. All right. Now, another question that can be asked here is, by Hoffman's degradation, we have a byproduct. We have a byproduct which is laudanocene. Okay, this is a byproduct of degradation, of Hoffman's degradation. This leads to a side effect which is neurotoxicity. This neurotoxicity leads to seizures. It leads to seizures in the patient. So this is one side effect that we need to know about. Okay. Now, atracurium, it has been modified into cis-atrac by taking in an enantiomer from here. Okay. Now, this cis-atrac has got lesser production of laudanocene. Okay, and hence is less neurotoxic. All right, so this is what you need to know about atracurium over here. All right, and atracurium and cis-atracurium, the difference of laudanocene you have to know. You have to also know that it produces histamine. So it causes a decrease in your blood pressure. All right, it can lead to spasm. This is also less with cis-atrac. Okay, so these are a few things that you need to know about atrac and cis-atrac over here, and you'll be able to easily solve your questions with them. All right, so one more thing, the dose that you give atrac is 0.5 mg per kg. This is the dose that you give, and this is 0.2. Okay, 0.1 to 2.2 mg per kg. So this will solve most of your questions. All right, so this is what we've done here about image-based questions in anesthesia. And again, I'll emphasize on the fact that whenever you're reading your theory for anesthesia, try to collaborate it with images. You can see them from Google, you can see them from your standard textbooks. It will not only help you in solving your questions in the exams, but it will also help you remember theory in a more easy manner and in a more thorough manner. So try reading it like that, and you'll definitely excel. Anesthesia is an extremely scoring branch in your MCQ examinations. So don't skip it. Try to make thorough notes of whatever we are teaching here, and you'll sail through. All the best, guys. Bye bye.